I want to thank Dr. Khanna and all the organizers of this meeting for this kind of invitation. And my talk is about endovascular treatment of aortic coarctation for which patients and which with endograft. Aortic coarctation represents an average of 7% of all cardiac malformations. The treatment can be carried out by an endovascular approach or by open surgery. The patient operated by for an aortic coarctation is never fully healed. It's important to monitor this patient for a long time. Indeed, treated patient is never fully healed. The long-term cardiovascular complications are frequent because aortic coarctation is not isolated, but is very often an element of a broad disease of arterial system. 95% of coarctation are located in the isthmus. Cardiac disease are frequently associated as bicuspid aortic valve and also ascending aorta dystrophic aneurysm and mitral disease. More the systolic pressure is high in postoperative, greater the probability of death. Deaths are related to the early onset of coronary lesions of endocarditis and our aortic or cerebral aneurysms rupture. Here are the different surgical techniques, especially Crawford technique, end-to-end anastomosis. Open surgery can cause early complications as residual aortic coarctation and persistence of hypertension, paraplegia, hemorrhage, and the mortality is about 1%. Late complications can occur as aneurysm and false aneurysm in 9% of patients and regurgitation ranging from 10 to 20%. The endovascular treatment is a true therapeutic alternative to surgery in the treatment of adolescent and adult aortic coarctation. The technical success rate is about 90%, and there is an early improvement of hypertension in 90% of cases, but it persists in more than 1/3 of cases. The mortality of endovascular treatment is about 0.7%, but with balloon angioplasty, there are risks of aortic rupture, aneurysm, and regurgitation with a rate greater than 15%. But with endografts, and especially with the covered stent, the rate of aortic rupture, aneurysm, and regurgitation is very low. A review of the literature reports the good results of the endovascular treatment, and our study that I will present to you confirms these good results. Regarding the choice of the stent, some authors claim that the self-expandable uncovered stent is safe and durable, but others think that this kind of stent do not have a sufficient radial strength to treat elastic lesions. And for the self-expanding covered stent, even if they protect against rupture, they also doesn't have sufficient radial force to treat the segment, the stenotic segment. The coarctation of the aorta stent trial caused the study was carried out to evaluate the effectiveness of the Sheatham platinum stent balloon. It reports on 100% technical success and an excellent reduction in coarctation gradients. Another study shows that this kind of stent has not been the cause of fracture or aortic dissection or aortic rupture, and that the use of a balloon in balloon delivery system may reduce the risk of migration during deployment. The CPBIB covered stent has other disadvantages as flexibility and rounded tips that prevent against rupture. Covered stent can prevent long-term aneurysm formation, but even though aneurysm formation rate is generally low, ranging from 0 to 4%. And regarding hypertension, whatever the stent used, arterial hypertension incidence sometimes is masked by ambulatory blood pressure mobilization or after exercise is much higher than those in healthy population. I will present to you our prospective study, a series of 53 patients, adolescent and adults, treated for an isthmus aortic coarctation between January 2014 and November, between January 2014 and November 2021. The mean age of this series is 28 years. Male is most often affected. All the patients were hypertensive. 29 patients had more femoral pulses. One patient had a pregnancy of 6 months, 2 patients had a stroke, 1 patient had a history of endocarditis, 17 coarctation were preductal, 36 were juxta and postductal, and the mean diameter was 2.9 millimeter, and the mean length of the stenotic segment 3.5 centimeter. The most common cardiac disease associated was bicuspid with aortic valve present in 20 patients. 2 patients had an ischemic cardiac disease, 2 patients had an aberrant right subclavian artery, and 3 patients had already undergone a coarctation operation, so they were treated for stenosis. All the patients were treated under general anesthesia. The access by the femoral artery was used in almost all the patients. The angiography was performed by a numeral approach. There were 2 technical failures. 4 patients were treated by self-expanding covered stent graft variant captive of Medtronic, 6 patients by a balloon expandable covered stent Advanta V12, and 41 patients by a balloon expandable covered stent CPBIB. The mean procedure duration was 45 minutes. The technical success was 96%. There was no left subclavian artery coverage, no operative complications, no day in intensive care unit, no femoral artery injury. For him, Thomas was treated medically. There was no stroke, no paraplegia, no renal failure, and no cardiac complications. And the quality of life was good in all the patients. Here are the pressure gradient. At the left, you see the pressure gradient pre-procedure, and at the right, the pressure gradient in post-operative. And immediately after the procedure, the pressure gradient dropped at 0 millimeter mercury in almost all the patients, except in 2 patients who kept a moderate 15 millimeter mercury of pressure gradient, 2 patients treated by the variant Captivia of Medtronic. So the transcoarctation pressure gradient that was in pre-intervention at 53 millimeter mercury fell back in post-procedure at 2.02 millimeter mercury. And for a mean follow-up of 48 months with extremes at 195 months, this coarctation gradient pressure remained stable at 2.2 millimeter mercury. During the follow-up, all the patients are femoral pulses. 12 patients have a normal blood pressure, 13 hypertension, but well controlled with 1 medicament, and 9 hypertension, well controlled with 2 medicaments. The pressure gradient is at 0 millimeter mercury, 37 patients, 10 in 10 patients, and 15 at 4 patients. The angio CT scan that is always down at 6, 12, and 24 months didn't show any migration and no fracture also. There is no restenosis for the moment. 1 patient have descending aortic aneurysm of 4 centimeter diameter and another short dissection. These 2 patients require only monitoring. You see here some photos, a photo of a patient treated by an endograft variant Captivia, CT scan at 1 year, another patient with the different steps of the insertion of the CPBIB covered stent. You see the dilation of the internal balloon, and at the right, the final results after the deployment of the stent. You see here another patient with very tight stenosis, difficult to cause by the femoral access. We finally caused it and pre-dilated it, and we inserted the CPBIB covered stent, and you see the final result at the bottom photo at the right. And you see the CT scan of this last patient in post-operative. Another patient, very tight stenosis, impossible to cause by a femoral access. We finally caused it by an humeral approach that allowed us to make a predilation. And after we came back to the femoral access to catheterize the aortic arch and to insert the CPBIB covered stent, and you see at the right the final result. Another case, postductal coarctation or aortic coarctation. You see at the right the CT scan at 12 months of these patients. Another case, another patient, you see in the middle photo, the dilation of the internal balloon, and at the right, the final results after the dilation of the external balloon and the deployment of the stent. The CT scan at 1 year of this last patient and the CT scan of this last patient at 3 months. And you can see here the excellent result. So in conclusion, after a review of the literature and the presentation of our series, it's will be true to assert that in adolescents and adults, treatment of aortic coarctation and recoarctation is currently performed usually by balloon expandable covered stents, that it is safe and efficient. Thank you for your attention.
Well, thank you. That was a lovely presentation of a good series of over 50 patients. And I think we're now going to have another video presentation from Frank Arco, who is in the United States. It would be about 5:30 in the morning for him. And so there's a video again on coarctation from Charlotte, North Carolina.